Hey, doctor, just one quick housekeeping thing. In order for each presenter to share their screen, you guys will just have to let me know as you go along who's presenting next, and I have to give them the privilege to be the presenter. Um, it's not like sharing control of the slide deck. I have to make them the presenter, then they can share their screen. So I'll just do each person as you go along.
Sure. Definitely. 1 second here, okay?
Yep, no problem.
Obviously, while we're doing that, I can just tell you the first two because I'll be starting,
Right.
and Dr. Rastovan will follow me.
Okay.
And so it's okay. You know what? My apologies. So I'm going to start. Next is Tony Wang.
Yep.
Third one is me again.
Right.
And then fourth one is Chad Rastovan.
Yep.
Fifth one is Dr. Yasmin Odia.
Got it.
And the last one is, the last
Justin
presenter is going to
Lathia.
be Dr. Lathia, and then it'll come to me.
Back to you.
But my last is wrap up and next steps. So it's
Okay.
not going to be any slides. It's just going to be
It'll just
we'll
be
in the gallery form. Yeah.
everybody's gallery. Okay. Well, that's fine. So when we start in a minute, I'll take down the housekeeping slide and then I'll make you the presenter. And then you'll be able to share your screen at that point.
Sure. Dr.
Right.
Odia just signed on. So Yas, do you want to check
Great.
your mic? And your video looks great.
Can you hear me okay?
Sounds good.
And you'll have the slides to share for me, or do I share?
I was offering for people to share it themselves. So
Nope.
Frank is going to help us. And, so yesterday I presented at the Rare Tumor Committee and everyone shared their own slide because it's just easy rather than saying next. So, so you can, we are able to see your screen.
Okay.
Okay. Well, I'm going to disappear from here, but we'll start we're about 3 minutes out. So,
yeah, so I do see Dr. Chad Rastovan signed on, Dr. Odia did, and the others, Dr. Lathia had signed on before you said, and as well as Dr. Tony Wang. So excellent, and I see a good group.
Hey, Manmeet.
Hey, Tony.
Hey, how's it going?
Good, how are you?
Good, good.
So good afternoon, everyone. Welcome to the first CNS Working Group meeting at SWOG. So I'm so excited to see a lot of familiar faces and also happy to see some new people who've reached out and looking forward to collaboration and our work together. So are you able to see my screen?
Yeah, looks good.
Okay, wonderful. So as some of you know, I just recently moved from Cleveland Clinic after spending close to 15 years there to Miami Cancer Institute to take a position here as the Chief Scientific Officer, the Chief of Medical Oncology, and the Deputy Director, and join Manesh Mehta, Yaz Odia, Rupesh Katocha, Martin Tam, as well as Alex Moeller, and we also have actually Dr. McDermott, who joined us from UCSF. So some movements, but very excited today to discuss to you about a SWOG CNS working group and looking forward to our partnership. So like all of you know, taking care of a brain tumor patient is a team sport. So similarly, we have a very multidisciplinary and evolving group or committee. And anyone you know who wants to be part of it, please feel free to reach out to them. We hope to have neurosurgeons in our group. We have a number of medical neuro-oncologists who are on the call today. Definitely have radiation oncologists, and you'll hear Doctors Tony Wang and Chad Rustovan. We intend to have allied healthcare people in our team, as we do in SNO and other places. We do have Dr. Lathia, who's going to discuss some of the work he's been doing in basic science, and we certainly hope to involve more basic scientists in our work. And we will, as you'll hear some of the proposals today, we'll have statistical support through the Rare Tumor Committee. Dr. Kurzrock has been very kind to house us in her committee. I've been part of that committee for probably 2 to 3 years, and several of you have attended that committee meetings too. So, going forward, we will have our CNS working group. So I will, in my final slide, you'll have my email. Please email me, and Marty, who's my admin, will orchestrate our CNS working group calls. We probably will take a vote how often people want to meet, but we are probably looking at 6 weeks plus or minus 2 weeks. So maybe 6 to 8 weeks, most likely, for us to have recurrent calls. And we will have twice a year meetings when we'll have the annual SWOG meeting. So with that, just want to give you a flavor of what's been going through, at least from the GBM perspective, what has been championed at SWOG in the last 6 months or so. Dr. Rustovan will talk about some of the brain mets things that he's been doing and some of the stuff that he has championed. So on the GBM front, a lot of you are aware of this study, which is the NRG BN007, which is a randomized phase 2/3 open label study of ipilimumab and nivolumab versus temozolomide in patients with newly diagnosed MGMT unmethylated glioblastoma patients. Dr. Andy Lassman from Columbia is actually the PI, and some of you on the call are also been involved in this study. This actually was put through SWOG. So if you are not an NRG member, but you're a SWOG site, we are championing this trial through SWOG, and official notification is in the process of going out to NRG Oncology about our desire to support this out of SWOG. And essentially what it is a randomized trial with the stratification factors of RPA and intent to use Optune. So this trial does allow use of Optune. And then people will be randomized with unmethylated MGMT promoter methylation status to get what we think is standard of care, radiation therapy plus temozolomide, followed by adjuvant temozolomide with option to use Optune. And the experimental arm is going to be a combination of ipilimumab and nivolumab, both in concurrent setting as well as an adjuvant setting. Now, in the arm 2, they decided not to allow use of Optune. So If you're an Optune heavy site, obviously there's a potential, but obviously, we know patients either at least want to have option of the best standard of care, and some centers are, more robust than others in use of Optune, which varies according to centers, but it is allowed at least in the control arm, not in the experimental arm. The phase 2 component is the progression-free survival component, and if it meets a particular benchmark, this will go to phase 3. And the target enrollment is 485 patients. So if you really think of it, it's a fairly large trial overall, because this is just for unmethylated patient population. So this will really translate to 800 or so patients if we were to look at the GBMS per se. But a great trial. Key eligibility criteria is histological proven diagnosis of GBM, or gliosarc is allowed on central pathology review. Unmethylated MGMT, as we said, by central path review. IDH mutation testing is there, and no mutation must be found. So this is a trial for IDH wild type. As you know, there's work going on in the next iteration of the WHO classification. IDH mutant GBMs will really not be, GBMs anymore. So because we know they do well. Obviously, this is newly diagnosed, so no prior therapy except for biopsy and resection. So that's what I would say is the this study. And then the next trial that we wanted to highlight is this study from essentially Alliance, and that's a study that is being championed by Dr. Gavin Dunn. This is a phase 2 study of checkpoint blockade immunotherapy in patients with somatically hypermutated recurrent glioblastoma. So as you know, there's a pan-tumor type approval for pembrolizumab for patients with high TMB. Now, as several of you are aware, SWOG has a study called DOT protocol, which is for rare tumors where they've used ipilimumab and nivolumab. Dr. Sandeep Patel's the PI with Dr. Young Chai, co-PI, and Dr. Kozrock have been instrumental in pushing that study, and it's been phenomenally successful. So we tried for 2 years to actually, and I presented several concepts around getting a hypermethylated or hypermutated recurrent GBM component in it. So meanwhile, Alliance was putting this concept, which actually got approved through CTEP, and this is glioblastoma, which is either can be IDH wild type or IDH mutant in first or second recurrence, which undergoes a surgical procedure to confirm disease recurrence, and on foundation medicine assay has a TMB, which is defined as more than 20 megabase per megabase pairs, TMB plus megabase pairs. They're eligible to go on this. And this is a 2-stage design. Stage 1 is going to be Nivo and IPI, 18 patients, and if they see more than one response, then they'll go into stage 2, which will be additional 14 patients. So 33 patient study testing, and there is drug support from BMS. The primary endpoint, as I said, is overall response rate here, because if you have one or more response in first 18, you'll go to stage 2, which is 14. The primary criteria here is TMB of more than 20 mutations per megabase pair on foundation 1 testing. Because it's response criteria, they do want measurable disease by RANO, which is bidirectional 1 centimeter by 1 centimeter. And as with most immunotherapy trials, this does have steroid restrictions with this. So these are the 2 trials. So thank you for being part of it. And what I would say is welcome to the group. I have my email here and also my Twitter handle. So feel free to contact me if you want to be part of this working group, and we'll make sure that you will get all the announcements going forward. Right now, we started with some people who had concepts, who had approached me. It's our first meeting. We want to be a very inclusive group, and we want to work together, because obviously our field needs that, right? So, and there's a group where we welcome new members. We welcome established investigators, but the essence here is going to be a very collaborative approach to work together. And if you have questions, I was told to put it in the chat box. So I think there was a question about IDH testing. Yaz, I will get back to you with that answer. I am not 100% sure since these are not trials where I have participated. Maybe Tony, I don't know if you have any idea since Andy works at your institution. Is that the NRG BN007 criteria?
I think there's a, I don't know if Andy's on, but there's a meeting, I think, if not this week or next week, and I believe that will be discussed. So I don't have an answer for that at this time. This is for BN007, right?
Yeah, and I'll reach out to Gavin Dunn, but that trial actually allows both IDH mutant and wild type. So I think the question is more relevant to BN007.
Yeah, and this is, I don't think IDH was going to be a criteria, but I could double check on and circle back.
I think on the slides that I got from NRG, it says that it should be wild type. So, but I think it will be a good point for us to know because, you know, obviously some of us are championing this trial through the NRG mechanism. But if you don't have this study, it should be available through the SWOG mechanism going forward since we are championing this trial. If there are no further questions right now, I would next ask Dr. Tony Wang, who has a very interesting concept of an open-label phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed MGMT unmethylated glioblastoma. And Dr. Wang is a radiation oncologist who has got great interest, extremely well known in the field in both clinical investigation as well as radiation, and has published successfully and is a thought leader, and we're very excited that he's bringing this concept to us. Tony, the floor is all yours.
Thank you, Manmeet, and thank you for the opportunity to present my concept at this CNS Working Group. I see a lot of familiar faces and some participants who are new to me. So yeah, my concept, as Dr. Ahluwalia brought up, is this is a phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed MGMT unmethylated glioblastoma. Next slide, please. So these are my disclosures and they're electronically available. Next slide, please. Since this is a CNS group, I'm not really going to go into too much detail here, but just in briefly, I think most of us who are participating here know that GBMs or glioblastomas is the most common primary adult brain tumor. They're the most aggressive. And the median survival, at least Roger Stoops' paper, shows that with the addition of temozolomide, the median overall survival is about 14.6 months versus just radiotherapy alone of 12.5 months. Next slide, please. I like to add that the benefit of temozolomide appears to be driven primarily by the MGMT methylation promoter. So MGMT is known to be prognostic with the median overall survival depending on its methylation status. If you have methylated MGMT, which is approximately 1/3 of our GBM population, the median overall survival with temozolomide is about 18 months. But the vast majority, or 2/3 of our GBM patients are unmethylated MGMT, and the median survival for that is about approximately 12 months. Next slide, please. So in terms of the predictive benefits of MGMT, if you look at the secondary analysis from Heggie in the same issue as the Stoop paper, adding temozolomide and methylated MGMT increased median overall survival by approximately 8 months, and in the unmethylated cohort, it was less than 1 month, I believe approximately 2 to 3 weeks as well. And so next, yeah, thank you. And so so as Dr. Ahluwalia had alluded to, there are ongoing trials, particularly addressing the unmethylated glioblastoma cohort, one of which is Checkmate 498 that closed using nivolumab as a monotherapy in the absence of temozolomide. That was a negative study, and there's obviously, as again Dr. Ahluwalia alluded to, NRG-BN007, which is using nivo and ipilimumab as experimental arm. So I'd like to bring in sort of a different aspect on the role of glioblastoma and some of the preliminary studies that have come out lately, particularly with the use of anti-IL-6. So this is a in vivo study looking at orthotopic glioblastoma mirroring models adding the anti-IL-6 antibodies, which in this animal study it showed that there was improved survival in mouse that got anti-IL-6 or combined treatment with anti-IL-6 and CSF1, although it seemed like mono antibody anti-IL-6 was just as effective by itself versus the control group. Next slide, please. And so this is a very important paper from our colleagues at Northwestern by Lamano et al., looking at sort of the mechanisms of anti-IL-6 therapy. So in this slide figure I want to show here is that what they found was that anti-IL-6 therapy helps reduce myeloid cell infiltration, and it helps increase T cell infiltration. Next slide, please. So this is a study, again, by the same group at Northwestern, in the same paper, actually, where the study here suggested that the combination of anti-IL-6 and anti-PD-1 acts synergistically in glioblastoma. So as you can see, they use C57BL6 mice and then delivered anti-IL-6 and anti-PD-1 treatments as the time scheme is as to the top right. And what they found, as you see in the bottom in figure labeled J and K, are both the tumor specimens and the reduction in tumor volume, as well as the actual animal survivals by control, monotherapy by IL-6 or PD-1, or the combination. And if you look at the bottom right survival figure, you'll see that the combination of anti-IL-6 and PD-1 was associated with a far improved median survival versus either monotherapy, and of course, worse off would be the control isotype. Next slide, please. So this is another study that was published a couple years before, looking at tocilizumab, which is IL-6 inhibitor from Genentech, that promotes apoptosis in U25 GBM xenograft models. Here, and I believe it was approximately 20 animal models using just tocilizumab alone versus control, showing that there was a reduction in both tumor volume, and again, proving in the bottom right figure that IL-6 in serum was reduced in animals that received tocilizumab. Next slide, please. So this is sort of another figure that I just blew up in the prior study from Lamano et al., looking at the combination of anti-IL-6 and PD-1, again showing that there was a better outcome in terms of survival in these GL261 tumor-bearing mice versus monotherapy IL-6 or PD-1, which was also, again, better than control, suggesting that perhaps it's the dual IL-6 and PD-1 that makes it more synergistically beneficial for these animals. Next slide, please. And so with that, the concept that I'm presenting here is a phase 2 newly diagnosed glioblastoma to give atezolizumab as well as tocilizumab in combination with radiotherapy. Patients would undergo standard maximal safe resection for newly diagnosed glioblastoma, followed by adjuvant standard radiotherapy of 6 weeks in combination with atezolizumab and tocilizumab, and then adjuvantly receive atezo and tocilizumab. The atezo and the tocilizumab are pretty much the standard dose that's being used currently. For tocilizumab, the dosing that's being given is what's been FDA approved for the use of RA. The primary endpoint here is 1-year overall survival. Historically, based on the STOOP, as well as other prior studies, the 1-year overall survival in patients with unmethylated MGMT GBM is approximately 50%. Our hypothesis is projecting 1-year overall survival about 70%. To do this with a power 80% alpha of 0.05, and I apologize, the number says 37, but it should be actually 47 patients we would need to detect a difference. And the accrual here would take approximately 18 months to do 47 patients, with a follow-up about 18 months actually. So I apologize for the numbers there, but that's based on our editing with our biostatistician. The major eligibility here is obviously newly diagnosed glioblastoma, and then I highlighted the unmethylated MGMT eligibility criteria, followed by adults and a decent performance status. Next slide, please. So secondary endpoints obviously would be to evaluate safety of adding atezolizumab and tocilizumab to radiotherapy. There have been prior safety data that's been reported at MD Anderson of atezo temozolomide radiotherapy, suggesting that it's safe. And there's currently ongoing atezo-toci combination trials for locally advanced prostate cancers and non-small cell lung cancers. The other secondary endpoint that we'll look at obviously would be progression-free survival. Other exploratory endpoints we'd like to do is quality of life, which could be done with questionnaires as per standard indexes, and also track steroid use and its association with survival. Future potential endpoints that we would love to look at would be to look at peripheral blood immunologic profiles versus overall survival and toxicity, and then ideally to look at to explore biomarkers, which would include PD-L1 expression, IL-6, P10, and pretreatment tissues that may predict for efficacy to overall survival and progression-free survival. Next slide, please. So in terms of accrual, I think this trial really design mirrors the other multiple completed as well as ongoing trials. Checkmate 498 as well as NRGB and 007 were studies that for newly diagnosed glioblastoma that omitted temozolomide without MGMT promoter methylation. Omitting temozolomide was not a barrier for accrual in either Checkmate 498 and currently for BN-007. We would allow steroids only if indicated, and I guess I also want to add here that we would also allow the use of bevacizumab as per other prospective trials have suggested. And this study follows the precedent of checkpoint inhibition and IL-6. Next slide, please. So this study follows the precedent of unmethylated MGMT only, no temozolomide, no placebo, and this would avoid the T-cell depleting effects of temozolomide in our experimental arm. And because of the unmethylated MGMT status, this will help shorten the follow-up period as well. And then next slide, please. And so with that, I'd like to also add that this concept has been discussed with the scientific team at Genentech. We're very excited, and we initially, with my colleague, who I believe is here as well, Dr. Fabio Emoto, with our scientific team at Genentech, we initially thought this would be great for a single institution, but now we thought that it would actually be even greater to run it at SWOG. And so with that, and I don't know if this is the time to ask questions or perhaps at the end, I'll leave it to Dr. Ahluwalia. Thank you for the opportunity to talk.
No, thanks so much, Tony, for sharing your very exciting concept. And so I would actually open the floor for questions at this time because it's a relatively small group and we want it to be interactive and collaborative. So feel free to have questions for Dr. Wang. If there is none, then I might start with one, Tony. So you mentioned about the steroids. So do you have a sense what you'll do with the absolute lymphocyte count criteria for inclusion and the steroid? Because that's one of the, the couple of things for.
Yes. So I kind of do, ideally what we want to do is sort of follow current ongoing concepts that are being used in terms of their steroid management and absolute lymphocyte counts. I totally agree with you. And actually, because Andy's office is just down the hallway, not too far away from me. So it's not hard to sort of keep a consistency language here that what we're following is kind of what we do is sort of standard practice. And I see Fabio also on the line. I don't know if Fabio wants to comment on that question as well, Fabio.
Yeah, I agree. I think the limiting the steroid very low dexamethasone use probably either 0 or 2 milligram maximum at the entry would make sense.
I agree.
Lymphocytes, can be lowered because of the steroids, which, but because it's newly diagnosed, I think will be less of an issue for the absolute lymphocyte count at the entry. But we could also put a parameter of minimum.
Right. That was a thought we had, Manmeet, about it, especially with, I think this is a study that I think Bearden's Checkmate study that suggested that the increased steroid use may have potentially negated some of the immunotherapy effects. So definitely on our minds about that.
Yeah, absolutely. I think, we saw that in Checkmate 143. Patients who did the best were those who were MGMT methylated and who were not on steroids. So obviously we know those, would be, the best group to begin with. But I clearly feel that as we design some of these trials, we really want to win. We are, our field really is looking for new therapies. So I think the concept is very exciting. Certainly has, my support. I'm presuming, people are here. We definitely want a couple of concepts to go through our committee. Dr. Chuck Blanke, who's the chair of SWOG, is very supportive, and Dr. Kurzrock, has basically told us that, she would be very supportive of, even 3 or more concepts going through a committee, a group during the first year. And there might be some resources, I'm told, which are available where we may be able to transition to a committee very quickly from a working group, which will mean that we'll all get, our resources directly, so which I think is, very exciting aspect for us. And the fact that you've already interacted with Genentech and there is interest there is a key component. So I think from our perspective, the next step would be to work with the Rare Tumor Committee statistician to, basically make sure that we have, good handle on the numbers, because that will be what will be interesting. And then get a pre-call with CTEP. The fact that, this is relatively, smallish trial, if I may call it, 47 patients with updated numbers, doesn't need to go through the brain steering malignancy committee, which will be, good, because we can hopefully move fast. And the fact that there's no ABTC now anymore going forward, there's no competing relatively small trials, right? So I think clearly I'm excited about this concept. And I think if people are interested, let Dr. Wang, Dr. Iwamoto, me know, obviously as we put our team together. Our big emphasis here is to make it collaborative and get people on, so that everyone has, it's got some kind of participation, active engagement. And thanks, Tony. Clearly very excited both for you and Fabio for this concept and to lead it to SWOG.
Thank you, Manmeet. And also, if you don't mind, I'm also going to thank Yasmin and Chad for giving me their feedback. I know they're presenting as well, and for Yasmin, we did also allow. Hey, Yasmin, we did also. I didn't put it there, but definitely the bevacizumab question. I definitely opened that for option as well. And Chad, thank you for the statistical question about the survival. So that's all been taken into account. So thanks for the feedback. I appreciate it.
Yeah, and it's our first meeting, so obviously, we want to present the concept and get the engagement going. In our follow-up CNS working group meetings that we'll have, we can always focus on 1 or 2 concepts per meeting and just brainstorm to make the concept the best possible when we interact with CTEP, because all of you who have been aware with or have worked in the cooperative group know persistence is one of the major attributes working in a cooperative group. But we, again, I think we're a tough group, and so very excited about your concept. So thanks, Tony. So next, moving on, can I get the slide controls? I would want to present a concept that I've been involved with, which will probably be a nice add-on to Dr. Tony Wang's concept. Okay, wonderful. So this is a concept, and it's TRC-102 with temozolomide in RT in patients with first-line MGMT methylated tumors. So Dr. Tony Wang had presented his concept, and this is several of you, part of this effort, because again, my intent is to make this group most collaborative, and we would love to get more people involved if they have interest. So please reach out to me. So obviously, this group knows this too well, but I just want to highlight for some of the people who may be on the call, may not be doing glioblastoma on a daily basis. We are one of the areas of interest which needs most therapeutic benefit, because I've been part of the Nccn guidelines, and we have this distinction of being one of the very rare tumor types where they say consider a clinical trial preferred for an eligible patient, and this is a recommendation ahead of standard of care. So if you actually look at the Nccn guidelines, all tumors typically they say standard of care or consider a clinical trial. In our field, especially for patients with anaplastic gliomas and glioblastoma, the clinical trial consideration is given precedence over standard of care, and we all work towards that and look forward to working more through this group. So this is actually a study some of you were involved with. This was done through the Adult Brain Tumor Consortium, and I actually had privilege of working with a lot of amazing people who mentored me through my early years in that group. and this was a TRC-102 and temozolomide in refractory glioblastomas. This was the ABTC 1402 study that we conducted through the APTC mechanism. So in a sense, as you know, this was work in the orthotopic xenograft models, which came out of Andy Sloan's lab at University Hospital's Case Medical Center, where he showed that TRC-102 plus temozolomide in xenograft models, you can see, had a very good outcome.
Sorry, doctor. Would you like me to share your slides for you? You're not sharing currently.
Oh, really? I thought I got the share mechanism, Frank.
I don't believe we're seeing your slides, though.
Did you make me the presenter?
Yeah, you should be able to just share, though.
My apologies.
That's okay.
And thank you for correcting.
There you go.
All right, my apologies.
Your screen now.
All right. All right. So this is a collaborative effort. So several of you have been involved. So thank you. And more people, if they want to join, just let us know. This is a slide which I spoke about, which was the clinical trial perspective over, the standard of care. So this is the TRC-102 and temozolomide study that we did through the adult brain tumor consortium, and several of you had contributed through that. So thanks. But here to give you the background. So when people get temozolomide, as you all know, there are a couple of adducts that are formed. One is the 0,6-methylguanine, then there's 7-methylguanine, and then 3-methyladenine adducts. We do know that and Dr. Wang talked about is the MGMT perspective, which is a very critical biomarker in our field. The 0,6-methylguanine adducts are actually repaired through the MGMT, which we all know is a repair enzyme. So patients who are methylated get typically the benefit of temozolomide. Patients who are unmethylated really only get a 24-day benefit. So we give 9 months of chemotherapy to our patients just for 24-day benefit. And that's why concept that Dr. Wang presented is really very exciting, because we want to up the game for those patients. Meanwhile, the patients who actually get temozolomide also have two other adducts, which is the N-methylguanine, now this is N7, and 3-methyladenine adducts. This is actually repaired by the base excision repair pathway. So think of it as a double hit approach that we often see in lymphoma and some of the other tumors. So this is, if you have MGMT that is altered, if you're methylated, so they have one lack of repair mechanism. So if we can hit them again with a base excision repair inhibitor, we could provide a double hit. So just want you to keep that in mind. So with that, TRC-102 or methoxamine is a base excision repair inhibitor that basically binds to the apurine site that is created due to the action of Npg. And this drug was developed by Dr. Stan Gerson, who was the Case Comprehensive Cancer Center director, and I and several of us had worked with him, which led to this orthotopic xenograft model that I was trying to explain, but you guys are not able to see the slide. So this is the picture. So if you give a combination of TRC-102 and temozolomide, you can see a profound benefit in orthotopic xenograft models. So this data was actually used to promote this trial, which was run out of the ABTC consortium. And this was a phase 2 study of patients who had first occurrence of glioblastoma, who were bevacizumab naive. Everyone got temozolomide and TRC. TRC-102 was given at flat dose of 150. We used temozolomide at 150 milligrams per meter square because all these patients were in first occurrence and had received the alkylating agent with temozolomide. And then this was days 1 to 5, every 28 days, and then the MRIs were done typically every 8 weeks, like we do. Rano criteria was used, and the combination was continued until 12 cycles of disease progression. Primary endpoint, and CTEP put a pretty heavy or a high benchmark for us. They said that the primary endpoint would be response rate, and they wanted us to achieve a response rate of 30%, which all of you will agree is something that we are typically not used to seeing in recurrent glioblastoma. There were a bunch of exploratory objectives, which included, looking at the Npg status, which is the N-methylpurine DNA glycosylase, which was done out of Lisa Rogers' work and the lab of Stan Gerson at University Hospitals. And we also looked at the MGMT status. So results which we had presented at SNO a couple of years back now were very similar to what we've seen in rectal glioblastoma. So as you all know, there is no drug that has ever shown even a single-day survival benefit in rectal glioblastoma. So this trial was unfortunately no different. We treated 19 patients. Median age was 16, KPS was 80, very typical. Median cycles patients got was 2, which is again very typical because that's the time to next MRI scan in our patient population, which typically with a non-anti-angiogenic agent will always show a progression for median number of our patients. There was unfortunately no responses seen, which is again not atypical of non-angiogenic based approaches. Overall median survival was 11 months, progression-free survival was 2 months. Progression-free survival at 6-month rate was 10.5%. Typical, so a typical story of any trial. But what we did here, and which speaks to the importance of tissue banking, right? So we were banking tissue, at least at Cleveland Clinic, of all these patients, and of these 19 patients, 14 were treated at Cleveland Clinic. And I actually treated 10 of those patients. And 2 of the patients that I treated did really well, actually. One of them had a progression-free survival for 18 months, and one of them actually went on even more than 30 months. I think she was like 32 months or so. And so we knew that there were a couple of people who were doing well. So keep that in mind. So then when we looked at the Npg staining, we had 0 in 6 patients, 1+ in 5, 2+ in 3. And the PFS, the progression-free survival that was good in 2 patients was associated with some Npg expression, which was good because it went with the process. We at least showed that the combination was safe. There was very low rate of grade 3-4 toxicities. There was a lymphopenia and a thrombocytopenia. When we looked at our outcomes now, when we broke it down, that's where we started seeing some very interesting results. So as you saw, overall, our median overall survival was 11 months, very similar to what we see 10 to 12 months, right? In unmethylated patients, we know it's around 9 months. In methylated patients, we know it's better, it's close to 12 months. So when we broke it down, the patients that we had in our protocol, and there were, I think, 5 patients who were MGMT methylated, their median overall survival, obviously small numbers, so this is hypothesis generating at best, we saw a median overall survival of 30 months. In unmethylated patients, it was 9.9 months, so no different. This was statistically significant, both in terms of progression-free survival as well as in overall survival, which is not different because we expect that every time you are using an alkylating therapy or a combination of an alkylating therapy with a DNA repair agent, as in this case. But the 30 months is highly intriguing. So what we did then was we took it further. We actually had tissue on these patients and at Cleveland Clinic, and luckily I treated several of those patients. So the 2 patients who actually did well, what we did was we actually sent over the tissue to TGen, worked with Mike Behrens there, and what we looked at was their RNA transcriptome, and what we found was there's a gene signature which corresponded with the 2 patients who did well. And here is the gene signature on the right of the 2 patients who did well. And then we had 1 patient who actually progressed right at the 6th cycle. So he, when you do the math, because a cycle is 28 days, did not meet the benchmark of 6-month progression-free survival, but he did, well on the borderline and had a borderline signature. And so these 4 patients actually who did not do well progressed either at 2 or 4 months, had a negative signature. So really excited to see this, what we are calling as an exceptional responder. So this trial actually was a follow-up to a CTEP trial that Dr. Nakabo and her group was doing, and we have shared this data with her and her team at CTEP, and they are very excited to see this because they're also seeing some exceptional responders on their colorectal study, and that's actually moving forward. So then what we did was we actually went and looked at, so 2 patients had the gene signature. So we actually went back and looked at it in the TCGA database, and again, this gene signature exists around 11%, so which kind of is in line with what we saw, 2 out of 19. And the good part here was this proliferation signature was seen in these 2 patients who did well. And what we did was then we wanted to look at the molecular subtyping, and the response to TRC102 was independent of the molecular subtypes, either mesenchymal, classical, or pro-neuro, because the 2 patients who did well. And so this is what I talked about was the TCGA, and TCGA around 10 to 11% of the patients who present in the TCGA database have this gene signature, which is seen again here on the extreme right. So with this, we've actually proposed a phase 1 trial. We've already talked to CTEP, which is very highly interested in this concept because they're working on this drug themselves. And we've also had discussions with Traycon, with their CEO and their leadership team, and they are fully supportive of this trial. And our intent is to actually do the study, and this will only be done in the MGMT promoter methylation patients. So they will come in and they will get the triple combo TRC-102 with radiation and temozolomide. So it will be a parallel study to Dr. Wong's study. And what we will do is this will be a dose de-escalation based on the fact that we've seen a lot of safety data already. None of the patients actually had discontinuation due to the combo when they gave it. So we'll start at a dose level of 75 milligrams per day in the concurrent arm, and then if that's toxic, we'll decrease to 50. And then 150 will be used in the adjuvant phase based on our previous data from the ABTC. And we will validate the DNA damage response pathway, the gene signature that I showed you, in the prospective manner to see if we can validate it even further. But again, the overall survival on 5 methylated patients was very intriguing and actually goes with the science, right? So you're doing the double hit. So this is the concept. I would love to get thoughts of the people while we actually, are building this. Again, I'm putting my email up there so that, people can note it and email me. And if you have any of the presenters, I'm absolutely happy to link you with them as well. And with that, I would love to open the floor for any questions that people have. And if they have an interest in the study, please reach out to me. We would love to partner with you. If there are no questions, then we will then continue our work. And the next, I would like to ask Dr. Chad Rastovan, who's at University of Colorado, and is a really force in the brain metastases world. He's been changing the paradigm. I know he's a big proponent of SRS and had a paradigm-changing paper in small cell lung cancer. The FIRE protocol, which he did, was a multi-center effort and is challenging the paradigm in the small cell lung cancer space. And floor is yours, Chad.
Well, thank you very much, Manmeet. It's a pleasure to get to present here, and I appreciate the opportunity. Are you able to see the slides I have up there? Okay, yeah, great. So I will be presenting actually 4 studies. One is a SWOG study and 2 NRG studies and 1 alliance study. So I'll move a little bit more quickly through these just so that we can get through them all, and then we can have time for questions at the end. So this first study is the SWOG S1827 study. It's also called Maverick, and this is a study that I have the privilege of leading with a great study team here. This is a study in small cell lung cancer, including both limited and extensive stage patients. And it's a randomization to brain MRI surveillance plus or minus prophylactic cranial irradiation. So very brief background, PCI has been around as a concept for a number of decades. Early studies demonstrated that it consistently reduced brain metastases. However, subsequently, we started to realize that there was also some neurological toxicity in patients similar to whole brain radiation. It became the standard of care after 2 landmark studies were published in the New England Journal of Medicine. The first was in 1999. It was a meta-analysis of primarily patients with limited stage disease, and it demonstrated what we always see, which is a decrease in brain metastases with PCI. And then when they pooled the data together, there was a 5% overall survival benefit at 3 years. And then subsequent to that, there was an EORTC study. It was a dedicated randomized study that was performed in patients with extensive stage disease. That was published in 2007, and that showed a significant overall survival benefit in patients with extensive stage disease. So after that, PCI became a standard recommendation for patients with both limited and extensive stage. Those studies were criticized or limited somewhat by their heterogeneous and often absent brain MRI staging and surveillance. So there's this question of maybe if we're catching brain metastases too late, perhaps that's limiting our ability to offer effective salvage therapy. And so to address that question, there was a dedicated Japanese randomized study specifically in extensive stage disease that was published in the Lancet Oncology in 2017. And that was a study that where all patients received brain MRI staging and surveillance, and then they were randomized to PCI versus no PCI. And in the context of that randomization, in extensive stage disease in Japan, there was no overall survival benefit with the addition of PCI. And so here we have just the key slides in extensive stage disease, the key figures from the European and the Japanese study. In the context of observation alone with no imaging, PCI demonstrated an overall survival benefit. But in the Japanese study, when imaging was being done regularly, there was no overall survival benefit. And the implications are that perhaps if we're doing surveillance, we can catch brain metastases early and offer effective salvage therapy. So that leads us to the contemporary standard of care for the NCCN guidelines in 2021. So in the green boxes, we have limited stage. And you'll notice that prophylactic cranial irradiation is still a Category 1 recommendation. It's still the standard of care. Why is that? Well, the Japanese study that raised question marks about the efficacy of PCI was only done in extensive stage disease. And the best data that we still have on limited stage disease comes from the meta-analysis in 1999. And then in the red boxes, you see extensive stage disease. PCI is a standard option. It's no longer a Category 1 recommendation. But when you look at patterns of care analyses, still about 50% of oncologists are recommending consideration of PCI for their extensive stage patients. So still very much a part of the paradigm, though it's treated as optional per the guidelines. And then in purple on the right, you can see that brain MRI surveillance is now the standard of care, regardless of whether patients receive PCI or not. So that brings us to the current trial. So the Maverick trial, SWOG S1827. This is a phase 3 randomized trial in patients with both limited and extensive stage disease. All patients receive brain MRI surveillance and plus or minus PCI. So you can see it's a very straightforward randomization. It's designed to be a pragmatic trial with very low barriers to accrual. All patients receive brain MRI surveillance, and it's a one-to-one randomization to PCI versus not. The primary endpoint of the study is overall survival. We have a number of other great secondary endpoints, including cognitive function and others shown there. The brain MRI surveillance schedule is every 3 months during year 1 and every 6 months during year 2, and that's concordant with the NCCN guidelines. One thing I would highlight, there's been a lot of interest in hippocampal avoidance whole brain radiation as well as PCI as a strategy to improve cognitive preservation. And hippocampal avoidance PCI is allowed on this study. It's something that we're tracking prospectively, so investigators declare a priori whether they intend to offer hippocampal avoidance to a given patient. And so that's we're able to track that rigorously. So that is an option. So, you can make this study, fit your practice patterns. And really, it does seem like one of the major question going forward is if hippocampal avoidance actually improves cognitive preservation, then comparing that to MRI surveillance is a very good question because we know that PCI is likely to reduce brain metastases. I would also highlight that various salvage options are allowed. Stereotactic radiosurgery is allowed for salvage, as well as hippocampal avoidance whole brain. And in the as far as eligibility is concerned, really any and all NCCN acknowledged first-line treatment strategies are eligible. Immunotherapy is certainly eligible, and patients can have that and go on to this study. So a few notes. So we're trying to cast a wide net. The study is open throughout the cooperative groups, including in Canada, and it's has a dedicated VA champion, and we're trying to specifically recruit VA patients as well to this study. It was activated right before the pandemic hit, and so accrual has been slower than we would have liked. It is open at many centers. Our accrual as of today is actually 36. There's a number of reasons for the slow accrual that include COVID, of course, which is applied to many studies, as well as competing trials in the small cell space. And it's also a bit of a challenging randomization. I've learned this firsthand offering enrollment on this study to patients over the last year. I think that framing is a really important aspect of this study. And it's just important to give patients an understanding of why PCI has been the historical standard of care, what our expectations with PCI are, including an expectation that it really does cut the incidence of brain metastases in half at 1, 2, 3 years, wherever you look in prospective trials. And for a lot of patients, that's really important, and that message can be buried if we only focus on cognitive toxicity. It's also important to frame the discussion around the fact that PCI remains the standard of care for patients with limited stage small cell lung cancer. There has never been a trial before this, a randomized trial, randomizing limited stage patients to MRI surveillance plus or minus PCI. And so also for extensive stage patients, we have conflicting randomized data now. So this is really hopefully going to be a tiebreaker study in that population as well. And we do treat the MRI surveillance alone as the experimental arm in this study. And again, I would just highlight that it's a very pragmatic design. We really want to make barriers to accrual as low as possible.
I can share your slides for you, doctor, if you need. I'm not sure why your microphone device would have disconnected, though.
Looks like Chad is going to try to call in.
Yeah, no problem. We can give him a few minutes.
While we are waiting for Chad, we have kept 10 to 15 minutes in the end for an open session, which will be a wrap up and the next step. So I know some of you want to make comments, so we'll have an open floor in the end for discussing new ideas. And I know Dr. Andrew Brenner has been spearheading a brain metastases trial in breast cancer, and we would love to hear about his efforts and offer that to our group too. Looks like Dr. Restovan's back in action.
Yeah, are you able to hear me?
Yes,
yeah.
we can.
Chad, I can hear you.
Great. So sorry about that. My call just dropped right in the middle. Thank you. Sorry for the interruption there. So the next study that I'd like to present is a recently activated study called NRG-CC009. And this is the study team here. I've had the privilege of working with Vinay Gandhi and some other great colleagues on developing this study. It's also a study in patients with small cell lung cancer. And this is for patients who have actually already developed brain metastases. And so this is a phase 3 trial comparing stereotactic radiosurgery versus hippocampal avoidant whole brain radiation. So by way of background, for small cell lung cancer patients, whole brain radiation remains the standard of care. And that stands in contrast to most other tumor histologies where for patients with limited brain metastases, we try to steer towards radiosurgery because of the preferred side effect profile. But patients with small cell lung cancer were excluded from the landmark trials that helped to establish stereotactic radiosurgery alone. And the historical concerns with offering radiosurgery alone in patients with small cell include specifically a concern for short interval CNS progression, which could potentially decrease overall survival in some small cell lung cancer patients if we were to miss our opportunity to offer effective salvage. And for this reason, people have been hesitant to withhold whole brain radiation in small cell patients, even for patients with a single brain metastases. However, at the same time, we also know that whole brain radiation can be associated with toxicity in some patients to cognition and quality of life. And strategies have been developed to mitigate that toxicity, including starting with radiosurgery alone, the addition of memantine to whole brain radiation, newer strategies such as hippocampal avoidance whole brain, and emerging systemic therapy alone strategies for specific patient populations. And then at the same time, there's also been emerging evidence that suggests that, at least retrospectively, that radiosurgery may be a reasonable option for some patients. And so this is a study that I had the privilege of being involved in that we published last year. And we brought together many centers from several continents to look at what the radiosurgery alone outcomes for small cell lung cancer brain metastases actually are. And so this was the FIRE SCLC study, and we were able to bring together 710 patients treated with first-line radiosurgery without prior PCI or whole brain radiation. And then we compared those data to patients who had been treated with the standard of care, which is whole brain radiation. And what we found was that the outcomes actually looked very similar to comparisons of radiosurgery versus whole brain in other histologies. Whole brain radiation was, as expected, associated with better CNS control, but that did not appear to translate into an overall survival benefit, which suggests that effective salvage therapy was possible for patients who developed brain metastases after radiosurgery alone. And to that end, after radiosurgery, it was encouraging to see that the majority of patients actually received further radiosurgery rather than salvage whole brain. And it was also encouraging to see that the rates of concerning outcomes like leptomeningeal progression and neurological mortality did not appear to be increased over historical series of whole brain radiation alone. And then in the whole brain space, there's been some sequential trials by the NRG that have tried to improve on the safety profile of whole brain radiation. The first was RTOG 0614, which was whole brain plus or minus memantine, and what they found was on their composite endpoint of cognitive preservation that memantine actually improved cognitive performance. And then building on that, they ran the NRG CC001 trial, where every patient received whole brain radiation plus memantine, and the randomization was to plus or minus hippocampal avoidance whole brain radiation. And there again, they found that there was an additive benefit of the hippocampal avoidant whole brain radiation, which makes this kind of the gold standard for whole brain radiation in terms of cognitive preservation outcomes. So that leads us to our trial schema. So this is NRG CC009. This is for patients with small cell lung cancer brain metastases who have 10 or fewer lesions, and it's a randomized phase 3 trial comparing radiosurgery alone to hippocampal avoidant whole brain radiation. The basic eligibility criteria are shown on the left: small cell lung cancer, KPS greater than 70 or greater than or equal to 70, 10 or fewer brain metastases, and a certain volume threshold as well. Patients are randomized, a very straightforward randomization to radiosurgery versus hippocampal avoidant whole brain. The goal is to accrue 200 patients. The primary endpoint is time to cognitive failure, looking at a composite of multiple standard cognitive tests. And the study is designed, excuse me, to demonstrate a cognitive preservation benefit with radiosurgery alone. And so then changing gears, we will go to a study that was recently championed by the CNS Working Group. And so this is Paul Brown's study Alliance 071801. And this is a study that is a randomized study for patients with brain metastases that have undergone surgical resection, and it's comparing single fraction versus multi-fraction radiosurgery to the surgical cavity. So for background, after surgical resection of brain metastases, there's a relatively high rate of local recurrence with surgery alone. Even after a good surgery, the rates can be up to 50% at 1 to 2 years. And so radiation has been used as a strategy to try to reduce the rates of local recurrence. And there have been a couple of randomized trials that were published in Lancet Oncology a few years ago, one that demonstrated that radiosurgery improved local control, and then another study comparing post-op radiosurgery to whole brain radiation, and what they found was that radiosurgery had a better toxicity profile than whole brain radiation. However, another thing that we've learned from those studies is that single fraction radiosurgery actually appears in these prospective studies to have suboptimal local control outcomes in the surgical cavity. The rates were somewhere in the range of 60 to 80% across the studies. And then we also know from non-randomized data that better local control outcomes have been reported with multi-fraction radiosurgery, which is delivered to a little bit higher dose, and it seems to potentially be associated with better disease control outcomes. And so the question is, you know, instead of single fraction, as was done on the randomized studies so far, should we be doing multi-fraction? And so that's what this study is designed to address. So this is a phase 3 trial comparing single versus multi-fraction radiosurgery to the surgical cavity. And so here's the schema. And so this is for patients with resected brain metastases of varying histologies. The brain metastases have to be moderate in size, greater than 2 centimeters. And here are the stratification factors. And then patients are randomized to single versus multi-fraction radiosurgery. The primary point is time of surgical bed recurrence. Here are the key eligibility criteria. Patients must have had a surgical resection for at least one lesion. The resected brain metastasis had to be 2 centimeters prior to surgery, and then the cavity has to be less than 5 centimeters after surgery. And then 0 to 3 unresected additional lesions, which would also be treated with radiosurgery. ECOG 0 to 2, fluent in English, Spanish, or French. And then exclusion, patients cannot have had prior whole brain radiation. They must be able to have MRIs. There must be no planned chemotherapy during the SRS. And the lesions have to be 5 millimeters away from the optic chiasm and brainstem. So status update for this study, it was activated in October of 2019. Its target accrual is just over 200 patients, and it's actually accruing extremely well. It's now up over 90 patients, so almost halfway through their accrual. And it was endorsed by SWOG, the CNS Working Group, in February. So we're excited to be a part of this study. It looks like it's going to successfully accrue, and it's a good opportunity to participate and get some accruals for the SWOG CNS Working Group. And so it's also just asking a great question. I mean, this comes up in practice a lot. Our default off study has been to offer multi-fraction radiosurgery in this setting at our institution because we've been impressed with the non-randomized data on that topic, but I'd much rather enroll those patients on this study to answer the question definitively. So I think it's a very good practical study, and it's accruing extremely well. And that leads us to the fourth and final study that I'll be presenting. And this is another NRG study. This is NRG BN009. And this one, just to unpack this title, so this is a phase 3 study looking at radiosurgery versus radiosurgery plus hippocampal avoidant whole brain radiation. And it's looking specifically at this concept of brain metastasis velocity. So if you work in the brain metastasis space, you may already be familiar with this, but it's a somewhat intuitive concept that patients who develop brain metastases more quickly tend to have worse prognoses. And there's this question of if patients are manifesting brain metastases very quickly, maybe salvage radiosurgery for those patients is not the best option. Maybe we actually have to try to use whole brain radiation to gain control in the CNS. And so it's asking that question specifically, and I'll continue to develop that as I work through the slides here. So as far as the concept is concerned, brain metastasis velocity, so there have been a number of studies with pretty consistent results that have shown that after patients have radiosurgery the first time, and then you track what their outcomes are after the first radiosurgery or second radiosurgery, what you find is that patients who are developing brain metastases more quickly have worse overall survival, and they have worse outcomes in terms of neurological specific mortality. And so this has been shown in a variety of data sets. And some of the preferred cut points here that have shown the greatest statistical significance are shown. Less than 4 does better. Less than 4 brain metastases per year does better. 4 to 13 is intermediate, and greater than 13 does worse. And so that brings us to our schema. The question is, for the patients who are developing brain metastases in the intermediate and high risk range, would the addition of whole brain radiation reduce neurological mortality by helping to gain control of the CNS? Is that the specific population where whole brain still has a role? And so that's the question of this study. So this is a phase 3 trial of salvage hippocampal avoidant whole brain radiation plus SRS versus SRS alone for first or second distant relapse after upfront radiosurgery for patients with greater than or equal to 4 brain metastases per year. And so one thing I'll highlight from the title is this is not in the upfront setting because radiosurgery is so well established and preferred in the upfront setting. This is really for patients who have already developed failures after radiosurgery. So that's just an important aspect of the trial to highlight. Basic eligibility, KPS greater than 70, no prior whole brain radiation, brain metastasis volume less than 30 cc's. Patients must have greater than or equal to 4 brain metastases per year at first or second distant relapse. Stratifications as shown, and then they're randomized. All patients would receive radiosurgery, and it's plus or minus the hippocampal avoidant whole brain component. The sample size is 350 patients. The primary endpoint is time to neurological mortality, and the lead investigators have done a really nice, rigorous job of trying to make that as objective as possible. There's a formal questionnaire that will be filled out for patients who pass away on this study, and then it's reviewed in a blinded fashion by multiple investigators, including a neurological oncologist with specific criteria for determining the potential for neurological mortality. Key inclusion criteria, as we said, brain relapse after first or second radiosurgery course, a brain metastases velocity greater than 4 brain mets per year. It includes non-small cell melanoma, breast, RCC, and GI malignancies, no prior whole brain or PCI. The study was activated in December 2020, and it was endorsed by the SWOG CNS Working Group in February 2021. And so it's still in kind of the local activation phase. So this is another study where it would be good to have SWOG participation and to try to get some enrollments on for the SWOG CNS Working Group as this group gets built up. And it's led by some great investigators through the NRG who have an outstanding track record of accruing to trials like this and moving the field forward. So we're happy to be involved in this study. And with that, I'll just put my email up here. If anyone has any questions, I know that was a lot to go through with 4 different studies, but please feel free to reach out to me. I'm happy to answer any questions that you might have, and thank you for the opportunity to present.
Thanks so much, Chad, for all the exceptional work you and several other radiation oncologists who are part of our group have been doing. So it looks like a very robust portfolio of studies. So if anyone is interested, Dr. Restovan had his email there. Please contact him, or if you contact me, I'll be happy to put you in touch with him. Any questions for Dr. Restovan?
Hey, I have a quick question. I'm Charlotte Rivers. I'm a radiation oncologist at Medical University of South Carolina, and I treat mostly brain tumors. And I was just wondering, for the small cell study that you were talking about for the SRS versus whole brain, does that include patients that have had surgical resection, or is it all radiation alone?
So there's no specific exclusion for patients who have had surgical resection. So a patient who happens to present that way and has urgent surgery, as long as they haven't had whole brain radiation, they would be eligible for that study.
Okay, great. Thanks.
So if there are no further questions, we're going to move on. Obviously, we heard about some exciting concepts in glioblastoma, ton of work in brain metastases. With that, we're going to change gears a little bit and have Dr. Yasmin Odia, who is the Director of Neuro-Oncology at Miami Cancer Institute, She's going to present a concept on phase 1/2 trial of pemetrexed plus selinexor for recurrent or refractory CNS lymphoma.
Thank you very much for this opportunity, Dr. Ahluwalia and SWOG, for the opportunity to present this concept in a highly unmet need, which is recurrent CNS lymphoma. As already stated, I'm Jasmine Aria, Neuro-Oncology Chief at Miami Cancer Institute, and I'm presenting a phase 1, phase 2 trial of selinexor plus pemetrexed for relapsed and refractory CNS lymphoma.
Yaz, you may want to swap your display because it's your presenter view.
Yeah.
So it's the third button on the top. Swap displays.
The third.
Yeah, if you look at the top, and show if you swap display, we'll see the whole screen.
Okay.
You may have a dual monitor, right?
Yes.
Yeah, or take it to the other side, which may be more difficult. But if you hit swap display, it'll take it to the other screen of yours.
Yeah, I'm trying to, and it's not. It's probably too convoluted with all the slides that I have. I mean, with all the. Oh, here. Did that work better?
Yes, perfect.
Perfect. Thank you. So my co-investigators are as listed: neuro-oncology is myself, medical oncology, Dr. Ahluwalia, and radiation oncology, Matthew Hall and Linares as a BMT representative. Regarding the rationale, we know that despite high-dose methotrexate, which is the backbone of all initial trial treatment, standard of care treatment for CNS lymphoma, many patients, in fact, go on to relapse and die from their CNS lymphoma. There is no standard of care for progression. Often it's re-challenging with methotrexate or numerous other options that are listed in this NCCN guideline. In fact, the more recent addition was actually pemetrexate as an approved salvage therapy for CNS lymphoma. And I then introduced selinexor, which is a first-in-class small molecule inhibitor of exportins or SINE inhibitor that has known activity in refractory, relapsed, and systemic diffuse large B cell, which represents the overwhelming histologic subtype of CNS lymphoma, in fact, 90%. We will present today the evidence for selinexor having CNS penetrance and why selinexor may have efficacy in CNS lymphoma and warrants further study in this particular subset. If we then describe some of the data available for pemetrexate in relapsed and refractory CNS lymphoma, pemetrexate is actually a multi-targeted antifolate, so in the family of methotrexate, similar to methotrexate, but with a broader spectrum of activity. In fact, there is some evidence of single agent activity in relapse refractory. There's actually numerous phase 1 and phase 2 studies in this space, but I present the one that will serve as our historical control, which is the one done by Razor et al. And published in 2012, looking in fact at relapsed primary CNS lymphoma. The median age in this subgroup was 69, which I think is comparable to real life distribution of age. KP is 70%. 10 out of the 11 had previous high-dose methotrexate and had therefore relapsed after this treatment. And the dosing, please note, is higher than the standard dose used in lung. It's usually 900 milligrams per meter square, and that's to overcome the blood-brain barrier for increased penetrance and activity. And it is still dosed every 3 weeks and still pre-medicated with dexamethasone as well as folate and B12 supplementation. The treatment cycles as defined in the study were 6 weeks. That means 2 doses essentially until complete remission, progression, or toxicity. The average dosing median was 5 cycles, that's 10 doses. And the overall response rate, that's both partial and complete, was noted to be 55% with a disease control rate of 91. The progression-free survival at 6 months was 45%. Toxicities were similar, but slightly higher in frequency than those for lung, not surprising given the higher dose specified. These were some of the sample of the progression and overall survival for these patients. And the major toxicity, as noted and as expected, in fact, were cytopenias, but fatigue and diarrhea were also somewhat common, though they tended to be largely low grade with a few grade 4 toxicities in thrombocytopenia, leukopenia, as well as anemia. Again, expected. In terms of selinexor and what we've learned so far, as I mentioned, it's a first-in-class SINE inhibitor that targets in particular XPO1. It's oral drug. It's administered depending on the study regimen, either twice a week or once a week. It has no known drug interactions to date, and a further review by our pharmacist concurred that there's no preclinical or clinical data to suggest otherwise. Over 3,200 patients have been treated with the drug alone across multiple tumor types, so we do have, I think, extensive toxicity data on the agent. And again, there's numerous studies in advanced hematologic as well as solid tumors. The main side effects for this, which we've seen across the board, are anorexia and nausea, fatigue, and platelet in particular. Among all the cytopenias is the most common to be affected. Treatment beyond 2 years has even been tolerated in particular subtypes and patients. It is currently approved for myeloma, and diffuse large B-cell lymphoma actually recently received approval. Again, this is a little bit about a schematic of its mechanism of action. In particular, note that it has some impact on tumor suppressor proteins and export outside of the nucleus, and that's in fact its main key activity. Its therapeutic window is in the G1, G2 arrest, and it seems that XPO plays a key role in cell progression, apoptosis, metastasis, and drug resistance. In fact, some data suggest that it not only has direct anti-tumor effect, it has a synergistic effect with other cytotoxic and anti-neoplastic therapies. And in fact, that is the key crux of the rationale for combinatorial treatment. Various dosing schemes have been targeted, and in particular 60 to 80 milligrams once or twice weekly has been the key dosing scheme for most studies. There's evidence in preclinical data and in human data that in fact there is a good plasma to brain concentration with a proven blood-brain barrier penetration. And this is a scheme of kind of registration trials that have recently led to approvals. And in particular, again, shown more in a schematic and the stage of development. If we look at the diffuse large B-cell recurrent study, this was the SADAL study. This allowed multiple recurrent diffuse large B-cell lymphoma, 2 to 5 prior treatments. They were subtyped as well, and they received 60 milligrams twice weekly in 4-week schedules until progression. And again, the cytotoxic profile was known, platelets being the more common scenario and also the most severe among the cytopenia, but fatigue and anorexia also noted, and lower frequency of things like ALT, AST, and other liver toxicities. With single agent therapy, the CR/PR median had not been reached at the time of this publication, and again showed a good response rate as well as a durable survival impact of the drug alone. And here the waterfall plot showing that a great majority of patients had at least some degree of tumor reduction, only a subset receiving reaching the criteria for true partial response. We also have data in GBM, and this I highlight mainly as an example of CNS penetration, where they did what is called the King study, which is recurrent GBM, using various dosing schemes of selinexor twice a week, once a week. And in fact, they decided on an 80 milligrams once a week. This is in distinction to the diffuse large B-cell lymphoma data because of the balance of both toxicity and efficacy, though the 60 twice a week was actually similarly effective. And this is what's led to the phase 1-2-3 combinatorial trial that is currently open and accruing for newly diagnosed GBM for arms A and B, unmethylated patients treated with selinexor alone, methylated patients treated with combination of Temodar and selinexor during the course of radiation and adjuvantly, and then in the recurrent setting, lomustine. There is discussions about combining in the recurrent arm with multiple other agents, but these are in discussion and not yet finalized. But it is a very complex multi-arm study. And so in summary, we know that there's anti-tumor activity in diffuse large B-cell lymphoma in phase 1 studies. but the efficacy in primary CNS lymphoma is unknown. We then present here a case as a proof of principle of a 55-year-old man with multi-recurrent diffuse large B-cell germinal center type that had gone through multiple lines of salvage treatment, including transplant, and unfortunately had recurred with CNS and particularly CSF disease as well. And so for his isolated CNS recurrence, he received expanded access selinexor in the way that it was dosed for diffuse large B-cell, which is 60 milligrams twice a week, I apologize. And here we see a patient with only monotherapy having a dramatic response, a complete response in one of the two lesions and a partial but near complete response in a second lesion over the span of a few months. Unfortunately, it was toxicity that led to discontinuation and ultimately recurrence of the disease. But here proving once again that there is one CNS penetrance and two activity in a B-cell lymphoma, and in particular in the CNS location. As such, we then present this particular study design, which is a phase 1/3 trial of selinexor plus pemetrexate in the relapsed refractory CNS lymphoma with a target dose of pemetrexate of 900 milligrams per meter squared every 3 weeks, and selinexor concurrently dosed in the diffuse large B-cell schema of 60 milligrams twice weekly. We would then encourage patients who are candidates to move on to stem cell transplant if not already received, or where necessary, whole brain if transplant is not a candidate, though these are a suggestion and left at the discretion of the investigator. There is a maintenance option of selinexor, which is 60 just once weekly. This is especially so for patients who do not receive transplant, who either received whole brain or received no other consolidative therapy. And these are the typical workup that we would advise for screening these patients, as is the norm, baseline slit lamp exam, CSF evaluation to assess for activity for disease there, PET scan for staging. We would advise a 3+3 design, starting with a 40 milligram dose and moving on to a 60 milligram dose, both twice weekly, for a goal of a maximum of 12 patients. I welcome thoughts on whether to start on 800 milligram also as a dose level -1 if there's concern about toxicity, and then increasing to a target of 900. Obviously, I welcome your thoughts on that matter. I know Dr. Iwamoto is on the call and is a trusted lymphoma expertise, so I welcome his thoughts on the matter. And the MRIs would be Q6 weeks and after transplant, and then a variable 4 to 6 months after. And consolidation regimens would be based on age, KPS, and HIV status. The statistics would then lead that if we create a sample size sufficient for a phase 2 component, this would only require 35 eligible and 40 accounting for a 15% attrition. And then ORR, the main endpoint would be essentially assessed only after the induction phase. In other words, before any transplant or whole brain takes into effect, so we can accurately assess the benefit of selinexor. In addition, the response criteria would be based on the primary CNS lymphoma criteria. And again, I recap the main side effects of selinexor, cytopenias particularly being thrombocytopenia. And with that, I welcome your questions.
Thank you, Yas, for your concept. Would open the floor for any questions for her.
Yeah, I think that's a great concept, Yasmin. I mean, as you know, there are few drugs that are both known to have anti-DLBCL activity and penetrate the brain. So, and I think that's a good combination, all outpatient. And I agree with you. I think putting the 2 dose levels for the pemetrexate makes sense because of the overlapping toxicity, especially myelosuppression.
So Yas, I have a question for you. So actually 2. So one is the dose of selinexor, between choosing 60 twice weekly versus 80 once daily, because again, the arm D in the King study was 80 once weekly. one is that, and the second one is obviously the rituximab angle, right? Because we know 90% of our CNS lymphomas are still diffuse large B cell, and they still, most of them tend to have the CD20 expression. So thoughts on those two?
Sure. I think both are very great questions. In terms of the Ritux, which I'll answer first. I'm actually in practice often use rituximab and pemetrexate. I think the issue is that the NCCN guidelines only specified pemetrexate alone and not rituximab. So in practice, I have found that often the insurances can give us problem when we try to combine the two. I welcome the thoughts of anyone here if they've had similar issues with insurance, either accepting one or not both. So my concern was that if it didn't get approved, then, and I was assuming it to be approved by insurance, would we allow that heterogeneity? In other words, some patients would be insurance approved for rituximab and some would not. I'm glad to incorporate it. I'm used to using it in standard practice whenever insurance allows it, but I welcome the thoughts on that. Regarding selinexor, this was in conversation with the sponsor. They preferred the diffuse large B cell, but they had not yet finalized their recommendations on it, whether they wanted us to use the GBM 80 once a week, or if they wanted us to use the diffuse large B-cell 60 twice a week. So I think that final discussion has yet to be had, but this was their preliminary suggestion.
Sure. So again, I think it's a great concept, and I think the next step, frankly, will be that we'll need to present before a lymphoma committee. We have one from SWOG, and maybe we'll welcome their input about rituximab question 2 before we reach out to CTEP. And now in discussions with you, I believe there is support from the company to support such a concept.
Yes, that we're very much interested in hearing the next steps on the matter.
Okay, wonderful. So I think, we all can use the CNS lymphoma protocol. There are not too many floating through the cooperative groups, and most of the lymphoma committees want to, obviously support something in primary CNS lymphoma, but they also have a number of their own concepts in lymphoma. So I think this would be a great one to go through the brain group. So with that note, again, excited about your concept, Yaz, and happy to, support it further with probably a next step would be a presentation with the lymphoma committee. So with that, we're going to change gears here. And just as I mentioned, we want our group to be truly translational effort, and a big component of that is of academic medicine is translating bench to bedside. So with that, I would like to welcome Dr. Justin Lathia, who had the privilege of working for over a decade, and he is a professor at Cleveland Clinic, and he's going to present some of the work that he's been involved, which has included a PO1 grant, of which he serves as a PI. Justin?
Hey, thanks so much, Dr. Alawalia. Can everyone hear me, and can you see my screen? Yes?
Yes.
Okay.
Yes.
Okay, great. So I wanted to sort of take you through a brief journey. I know it's Friday afternoon. I want to end the week off with something a little bit thought-provoking that you can sort of mull over the weekend. So this is my contact information. So if anything that I say piques your interest, by all means, reach out. So, my lab has traditionally been a cancer stem cell lab, and we've embarked on a journey that really, we started asking the question, how do these cancer stem cells, which, as many of you know, have been the target of interest for a lot of next generation therapies, how do they suppress the immune system? And we really stumbled upon an interest in this group of cells called myeloid-derived suppressor cells. I'll tell you a lot about them in great detail, but we've been interested in them in a variety of ways, both preclinically as well as clinically. And we're in the process of asking these questions. And again, this is part of my team that's been working in this area. So, these cells actually do provide an opportunity to better understand interactions with the immune system. And I know it's a busy slide, and this paper is in press right now. So once it becomes unembargoed, by all means, feel free to look at it. But what's exciting to us preclinically is a lot of the things that have been developed and identified are actually being appropriately translated by great clinical colleagues like yourself. So again, this is just a brief summary, but this is to really highlight the point that the interaction between the immune system and cancer stem cells is quite complicated. Now it gets even more complicated because there's a wide variety of cells within the tumor microenvironment. And what you can see here on the left is just a pictorial, a cartoon depiction of that. And again, my lab's been really interested in myeloid-derived suppressor cells. And again, I suspect many of you have heard of them, but I want to take you through some of the high points that we've been thinking about and really end with this idea of an opportunity to enhance precision medicine through the concept of sex differences. So what are these cells? So these cells actually are emerging out of normal hematopoiesis. But when a tumor is on board, you end up getting a variety of subtypes. We often call them the monocytic, or the MMDSC, and the granulocytic, or the PMN NDSC. And you can see that they can emerge from aberrant differentiation. And within the field, there's still a variety of outstanding questions as to what they're doing. But I think it's pretty strong that they are a resistance mechanism. And in glioblastoma, which I'll show you in a second, they're quite high. Within the lab, we've done, what a lot of people do. We've done some single cell sequencing from mouse and human, and we find that there's heterogeneity. So this is something we're working on and happy to discuss. They're very complicated. So this is a very simple summary slide of what they actually look like, both in humans and mouse. And you can see that there's not really great concordance. And there's a variety of regulatory mechanisms that underlie that. And especially for this audience, when you're thinking about what your drugs may be doing, I mean, there's a lot of factors on here that clinically there's opportunities to go after, whether it's GM-CSF, IL-6, STAT3, and so on. So what we thought about years ago is, obviously we're a translational lab. We're very interested in basic science questions, but we want to partner with folks like Dr. Ahluwalia to get things into the clinic and then sort of reinvent hypotheses through assessment of clinical samples. So essentially, we published this a couple of years ago, but we actually found in a large cohort at the Cleveland Clinic and in collaboration with groups in Denmark, as well as at UCLA. And again, this was led by Tyler Albin, a PhD student in my group, and in collaboration with Alvaro Alvarado, who's at UCLA, who's actually my first PhD student. So what they basically were able to demonstrate was whether it was in the blood or it was in the tumor microenvironment, patients that had a worse prognosis in terms of glioblastoma actually had an accumulation of myeloid-derived suppressor cells in both tissues as a function of time. And we did things like mass cytometry time of flight to reconstruct the immune system and get a real solid look at the different lineages that are being impacted. And what we hypothesized in this paper is that patients that did better had less myeloid-derived suppressor cells, and they were actually differentiating. So, this got us thinking that they seem to be high in tumors. Can we design ways to go after them? So one of the ways we did that was actually low-dose chemotherapy. And this was based on a series of observations from a group in France that was trying this in a melanoma model. It was actually really excited to see the first part of today's talks where both Dr. Wang and Ahluwalia showed a lot of preclinical data which inspired some of their trials. And I think this is another example. So within our lab, we went after these cells using this paradigm. If you actually look in the circulation, we could deplete myeloid-derived suppressor cells. When we engrafted luciferase-bearing tumor cells, what I hope you can appreciate is there is nearly a black and white difference here. And again, we've got to get the dose right, but we can achieve a pretty strong preclinical signal when we do this. And what we would hypothesize is if we take off the suppressive arm of the immune system, you would anticipate seeing things like CD8 positive T cells flood the tumor microenvironment. And that's what we saw. So this was really the basis for a recently completed clinical trial that was run out of the Cleveland Clinic. It was led by Doctors Peerboom, Ahluwalia, and Vogelbaum all together. So essentially, we were able to do this. So they went ahead and did this with capecitabine. So this is the oral prodrug form of what we used. And if you compare it to the newly diagnosed patients, so these are in black, and every shape is a different blood draw. You can see over disease time course, in general, you see an enhancement in these cells. But when we go in a dose-dependent way, we can actually reduce these from the circulation, and that's better summarized here. So this is just providing us a proof of concept that we were able to translate some of the findings on MDSCs from mice to humans and actually reduce the levels in patients. So this is a real good start. So what are we doing next? Next things we're thinking about are resistance mechanisms. And, yes, there's been success in immune checkpoint inhibitors in a variety of advanced cancers, but it actually turns out that one of the resistance signatures we see as an increase in MDSCs in the circulation. So this is a paper in melanoma, but in an unpublished cohort at the Cleveland Clinic, and this trial was led by Dr. Ahluwalia, you can see the same thing. In patients that don't respond, we see an enhancement in their MDSCs. And what we're currently doing, and we're just finishing writing this paper, but we're really leaning into this difference between a responder and non-responder, and we're employing some high-resolution technology. In this case, it's a site-seq, so this allows us to use barcoded antibodies in combination with single-cell RNA sequencing. So we're really getting a better handle on what's going on, and we think MDSCs are related. But what I really want to do is sort of get you thinking about MDSCs in a slightly different way. So one of the things we've been trying to answer in my lab over the last couple of years is what are the differences between the subsets, right? We think that there's differences maybe by cell surface marker, maybe by localization, maybe by function. And this was work led by Daphne Bayek, who's a very talented postdoc in our group. And what she found, and it was published last year, is very interesting, is that unexpected to us, we actually saw a sex difference in myeloid-derived suppressor cell biology. So we actually saw that in males, there were more monocytic subsets in the tumor microenvironment, and in females, there were more granulocytic subsets in the periphery. So, I'll just show you some data on how we got there. We do a lot of mouse modeling, and essentially, it doesn't really matter. I shouldn't say it doesn't really matter. We have a variety of syngeneic mouse models that when we transplant equal numbers of cells into males and females, we actually see a sex difference. So it turns out that males with the same tumor cells, same number of tumor cells, actually succumb to disease faster than females. And you can see that on the top part of the slide. And when we do bone marrow transplantations, for example, we can transfer the phenotype. And that really got us thinking about the parallels to humans. And this is epidemiological evidence that you're seeing on the top right. So there's actually two groups. There's a blue group and a red group. And if you look at the incidence curves, it's not mutation, it's not environmental factors, it's actually biological sex. And if you look very carefully on the upper left, this is work that was led by Jill Barnholt-Sloan as part of the Ohio brain tumor study. And she was actually able to demonstrate that when adjusted for all clinically relevant variables, males still do worse. So, males get glioblastoma 1.6 times more frequently than females. Males have a poor prognosis. And you actually see this trickle down for a lot of other CNS malignancies. Meningioma, for example, would be the opposite. Females get it a lot more often. If you take a deeper dive, and this was work that was led by Josh Rubin at WashU, he saw something similar in terms of the molecular genetics as well as imaging. And actually buried deep within that paper in the supplement is a really elegant drug screen where the team looked at both mouse and human glioma and glioblastoma models and cells and did some drug screens. And it actually turns out, surprising to us, things like temozolomide are actually way more effective in female cells than male cells. It gets even more complicated because if you actually look at sex differences across the immune system, you see something quite interesting. It turns out that autoimmune diseases have a female bias, right? You could think of multiple sclerosis, lupus, the incidence is higher there. There's actually a bias towards males in terms of cancer. And I should back up and say that, in the era of COVID-19, we see the same thing. We actually see a sex difference in COVID-19 immune response. So we tried to model this a little bit better in terms of the MDSC part in preclinical models, and we looked both at males and females. And interestingly enough, what we found is we chelate granulocytic MDSCs or MDSCs as a whole, we can actually move the needle in terms of survival of mouse models in females, but not in males. And we actually tried to model this a little bit better using RNA sequencing to find gene networks. We weren't that successful, but we were able to take the same data and run it through a drug repurposing algorithm. And this was in collaboration with Fei-Shuang Cheng, who's one of our informaticians. And we started getting classes of drugs that were predicted to work either on monocytic or granulocytic subtypes. So for example, the monocytic subtypes would be things like fludarabine, fluorouracil, or capecitabine. So to remind you, we had published earlier preclinically on fluorouracil and clinically on capecitabine. And then members of the IL-1 beta signaling family of inhibitors came up in females. So really the proof is in the pudding. So what really got us excited is the reality is we could actually use these repurposed drugs and actually get survival signals in preclinical models. So what I hope you can appreciate, if you look at the green group in males, when we give fludarabine, we're able to actually increase survival. You don't see that in females. And in females, however, we can go after things like IL-1 beta and get a survival signal, which we can't appreciate in males. And again, this is just more validation showing that we've got on-target effects that you can see in the upper right. So this really sets us up, and again, in this paper, we did a lot of human validation as well. So this really sets us up to think about the disease a little bit differently. And the fact of the matter is, do we have therapeutic modalities that are impacting males or females differently? Because we know inherently the incidence is different, and it seems like the molecular genetics may be different, and the immune response is different. So again, work in our lab is trying to think about this a little bit more deeply right now. And I will tell you, at least as a teaser, is a lot of this is not sex hormone driven. Through the publication process, we were pushed by reviewers to demonstrate that, this had nothing to do with sex hormones. So we were overtly castrating or oophorectomizing mice. And we don't think this is solely driven by sex hormones. So what are we doing now? So after that initial study, we're partnering with Dr. Ahluwalia in collaboration with Novartis to try to use an anti-IL-1 beta inhibitor. We're obviously trying to assess immunotherapy response for additional targets. So that's some of the stuff I sort of showed you before with techniques like CytSeq. Within the lab, we're very focused on the lineage relationships and really the fundamental biology of myeloid-derived suppressor cells. We're expanding the idea of sex differences to other immune cell populations. For those of you who think about microglia, they're another example of a cell type that has profound sex differences. And then finally, we are starting to think a little bit about the role of the microbiome, given everything that's going on with immunotherapy response. And we think MDSCs underlie this. So this is sort of the last slide I'll leave you with. And if you actually look very carefully, there seems to be really strong sex differences at a variety of different levels. So, if nothing else, hopefully, when you're thinking about your clinical trial designs, you might be able to think about this in some way. Again, show the folks in the lab, I highlighted the key members, and then great collaborators throughout the US and the world, and obviously the funding agencies. And this in particular was supported initially by the American Brain Tumor Association and is now part of a large NCI-funded program project grant. So I'm happy to stop there and take any questions.
Thank you so much, Justin, for sharing all the exceptional work you and your lab have done. And I think, it's we are at an inflection point in GBM where we are, really looking at it as a heterogeneous subset of patient population as it is. If there are any questions for Dr. Lathia, then, please pose it. And if you want to get in touch with him, feel free to reach out to him, or you can email me and I'm happy to connect. And hearing no questions for him, I'm actually going to open the floor right now. We have around 17 minutes left with us. We do understand it's Friday afternoon. Probably most people had a long week. But with this would be an opportunity for people if they want to just share their videos so we can see each other. Also, I do know that, Dr. Andrew Brenner wanted to talk in particularly about a trial that he's leading out of SWOG in the breast cancer brain metastasis space. So Andrew, do you want to share a little bit details about your study while people sign on? And then I would love to hear what people may want to see in this platform, because we want to really make it collaborative.
Yeah, I appreciate it. Thanks for letting me talk about 2007. We started working with sacituzumab govitecan before its FDA approval when we saw very nice responses presented for triple-negative breast cancer. For those who are not familiar with some of the breast cancer therapies, sacituzumab govitecan is an antibody-drug conjugate that specifically recognizes TROP2, and the payload is SN38, and showed a 35 or greater % response in heavily pretreated triple-negative breast cancer metastatic patients. And it's a very unique ADC in terms of the linker. It is not a tight linker like you think of with other drugs such as Kadcyla or TDM1. The linker is pH sensitive. And so when it gets into the tumor microenvironment, it can dump SN38. Some of you are familiar with SN38 from using irinotecan in the past. It's the active metabolite of irinotecan, and it's about 1,000 times more potent than irinotecan. The IC50s for SN38 are in the single-digit nanomolar range for most tumor types, including for breast cancer. So we did some animal modeling, intracranial injections of breast cancer cells and treating with sacituzumab, saw very nice responses, and then did a pilot study in patients who were going to craniotomy for breast cancer brain mets, treated them with sacituzumab, and resected the tumors and allowed them to continue on sacituzumab. And we saw drug concentrations averaging close to 500 nanomolar all the way up to micromolar range, which is 40 to 50-fold the IC50 for SN38. So we now are going forward with the study of sacituzumab for patients with breast cancer brain mets who have already failed either surgery, radiation, or both. And they'll receive standard doses of sacituzumab govitecan, 10 milligrams per kilogram IV, day 1, day 8 of a 21-day cycle. It just activated in December. We're just getting started. We only need 40 some odd patients. So I would really encourage you, if you think that you have some of these patients there, make sure that you guys open the study. Please try and accrue. I'd love to get an answer to this. And we are set up such that if it's a positive study, the data will be used to change the labeling for sacituzumab.
No, sure. Thanks so much for sharing that, Andrew. I think it's an exciting trial. So anyone who wants to be part of it, reach out to Dr. Brenner or reach out to me, and I'm happy to connect. But certainly we'll Andrew, have you come and present this in our next CNS working group so people can actually see the slides. And that'll be awesome. At this time point, we still have more than 10 minutes. If anyone would like to, say a few things about their interests so that we can get to know each other better, or anything that you would be interested in bringing, brainstorming, again, because we're a group in a infancy, if I may add, and I'm excited about our potential opportunities here because ABTC, as you know, is going out. Alliance and NRG has done the lion's share of, pushing work through the cooperative group mechanism and ECOG as well. But some of the studies, as you saw, concepts today were relatively small, so we can, fill in that niche space, which the ABTC did to serve. And then as you heard, several of these concepts can then go on to be larger concepts because they are all driven by science. That's one of the things we are trying to do as part of our working group, is basically to have science, because we all otherwise get stumbled at CTEP or brain malignancy steering committee, and it takes a lot of effort to get these protocols through. If no one is going to speak, I'm going to pick on Karen, since she has been such a leader in the field. And Karen, so good to see you.
Good to see you too, Manmeet.
Any words of advice, wisdom for us, or anything else you would want to see?
Just have to keep keeping on, because we've had an awful lot of negative trials. I like everything I saw today. So I really appreciate having something for the methylated patients, because a lot of folks are doing it unmethylated trials. So anyway, great.
Thanks so much, Karen. And anyone else, again, feel free to reach out to me or anyone else who gave talks today. And certainly, if you have ideas, we would love to develop them and then offer resources that we have collectively. Because again, as Karen alluded to, we all get humbled in our field, right? So unfortunately, and we all want to have therapeutics whenever we knock at any of our patients' doors, because in recurrence, we know there's almost a 50% chance if they're having an MRI, it's going to show progression, at least in the GBM space.
Hey, Manmeet, I've actually been working with Mike Behrens on a trial of arsenic trioxide. And so seeing the methoxamine data was very exciting. And I think this might be the forum for trying to do that trial. It's another one where there's a genetic signature that's in 10% of glioblastoma, and the company is interested in supporting, but only giving drug. So I'll talk with you offline about that.
No, absolutely. And we can have you present some of the data. I'm obviously aware of some of this stuff since we have discussed this previously, but that would be a great venue for you to present your concept. And, let's try to see if, because the cooperative group mechanism is the way to take the drugs to studies where there may not be, support in terms of actual finances. But, and especially we want to do a number of these biomarker driven studies because we want to learn from that, and the TRC 102 is a good example, of that effort, and I'm obviously excited about the concept that Dr. Wang presented today too.
All right.
If no other comments, then I might actually just end this session and give 10 minutes to people back in their lives. Thank you so much. Really very happy to see a robust participation, and I look forward to working together.
Thanks, Manmeet.
Thank you.
Thank you. Bye.